Typically, with shorter appointment times, patients don't bring issues up that are bothering them, and that's because there's a lot of issues that you have to dig out of seniors because they won't bring them up. And specifically, Dr. Ham a number of years ago tabulated those. If a senior comes in by themselves, they're often not going to talk about depression, incontinence, osteoporosis, hearing loss, certainly not about memory loss. It's very usual for me to have a senior sitting in the middle of an exam room and the daughter-in-law over in the corner, and I'll ask the patient, how's your memory doing? And the patient will go, oh, just fine. And the daughter-in-law is over in the corner going, no. So, they won't bring it up themselves, and there's a lot of case finding that has to be done, and you just can't do that in a 12 or 15-minute office visit appointment. So specialist issues as it relates to seniors. Sometimes you can actually get into a specialist sometimes quicker than you can get into a primary care doc. That's not always the case, but it's more costly to the healthcare system. And many specialists do not have training with specific geriatric issues. So I love my cardiology friends, but I'll sometimes see one of my patients come back from my heart doctor friends on drugs that I sort of shiver about, because more so than I'm shivering up here right now, because they're not appropriate for seniors. And if you're going to a gazillion specialists, you end up with a lot of polypharmacy, and that's not good. It's fragmented care. So let me briefly start talking about solutions, and I'll tell you first of all, there is not a single solution right now, because every solution that I've seen thrown out has some hurdles and drawbacks. Many are going to take time to develop, and I think right now we're kind of in a brainstorming mode where we've got to say, how about this? Okay, let's play with this idea or that idea. So let me tell you about some existing solutions. There's Medicare Plus Choice plans, and those are things like Rocky Mountain HMO that's over in the Grand Junction area, or Kaiser technically is similar to that. And those will oftentimes provide seniors access. But oftentimes there's some drawbacks to that. I used to sit on a panel for a thing called Colorado Foundation for Medical Care, where I would try to review decisions when people were being refused services at nursing homes or assisted livings. And a lot of these plans will not cover as much rehabilitation for, say, a fractured hip or a knee replacement as standard Medicare. That's how they make up their dollars, and you have to kind of start arguing with people about, gosh, doesn't grandma need to stay longer to get these things? So there are some hidden drawbacks in these kind of plans. Another program that I'm very, very fond of, which kind of addresses one of the issues that Dr. Staffer alluded to in the domain of keeping frail elderly at home, is a thing called PACE, or Program for All-Inclusive Care of the Elderly. There's a big one down in Denver, or a big program for the Denver. It actually started in San Francisco with a thing called the On-Lock program. That's kind of a combo of daycare and medical services where people get to stay in their own home but go to a central facility during the week and get meals, plus medical services, podiatry services, social work, rehab services. So but it has to be regionally approved. Fortunately, it's one of the areas that still has funding available. Some options that you'll hear about in the media. You'll hear a lot about, how many of you heard about patient-centered medical home? Anybody out here heard that? Okay, that's a buzzword right now that particularly family docs and general internists and pediatricians are saying we want to make our office a patient medical centered home, and the presumption is that you'll be able to provide more care to people like seniors. That works really well for larger groups like associates in family medicine or other large groups. It doesn't work as well for smaller office-based groups, and it's one of those things where it's kind of like Field of Dreams. We're hoping that if we build this, the funding will come, but the funding is not there for this yet, so maybe it will be. We'll see. A lot of people will say, oh gosh, just let's get more practitioners and they can provide the senior care. That also works okay in larger cities. There's some good models for that in New York City where there's some large NP groups. But they still need physician oversight, and I have a feeling that the economics of that is going to change. There are some other brainstorming things that are going on currently. There's a large foundation called the Donald Reynolds Foundation grants that are in 4 major areas across the country offering to retrain physicians to do more geriatric-friendly care. It's kind of a low-volume type program, but it is helping. There's an idea that came out of the migrant health worker context, which is why don't we train lay volunteers as case finders? That's sort of in some sense like although these aren't lay people, like the parish nurse program, where you might have a volunteer nurse or a trained layperson within a given social group who would say, hey, in my neighborhood on Wakanda Drive, are there older people there that need help, and I'll try to get them into services. An idea I'd like to see the feds do, there's a lot of loan forgiveness programs if you practice in a physician underserved area. What I'd like to see is an age-specific loan forgiveness program. Because if you have a young doctor who's got $200,000 worth of loans, but you say to them, if you accept X% of Medicare into your practice, we will decrease your loan repayment by X amount per year, I think you get more docs doing that. So that's another idea that I've heard about. So what we need to do, again getting back to my quote from Network, I really want to see our group in Larimer County, and we're going to have to start spreading this beyond Larimer County, start brainstorming on some ideas, start shaking some trees, particularly the politicians and the chief financial officers of various organizations, and find out who is going to provide and fund health care for seniors. So, thank you.